Hello everyone. Wound care is an important topic among the healthcare professionals. So I would like to do a short video on this wound care and touch in the essential areas of wound care for doctors, nurses, medical students, nursing students, and for anyone who is interested in wound care. So let's move into the wound care. So first of all, what is a wound? So wound is a disruption of the normal structure, function of the skin and the soft tissue architecture. So a very important thing to understand is it is the disruption of the normal structure, and due to the disruption, the function of the skin and the soft tissue architecture are disturbed. So in this short video, I'll be lightly touching the wound definitions and their classification, and acute and chronic wound care, wound dressings and wound packing, and a brief discussion on diabetic food management and best practices of wound care. So let's move into the acute wounds. So what is an acute wound? So they occur suddenly, and usually they have an easily identifiable mechanism of injury that causes the disruption of the integrity of the skin. So the most important thing is they follow the normal physiology of wound healing, and they follow the normal stages of wound healing. So these are the normal stages of wound healing: hemostasis, inflammation, proliferation, and the remodeling. So during the acute wound healing, they follow these 4 stages: abrasions, the cut injuries, and the surgical wounds. That for the surgeries we cut through the skin, and those are examples for acute wounds. So chronic wounds, so they are the ones that have the impaired physiology of wound healing. So they take lots of time to heal, and there's a disruption of the wound healing cycle, and they do not heal in the expected time frame. So examples are the non-healing surgical wounds, the infected surgical wounds, venous ulcers, arterial ulcers, and pressure-induced ulcers such as bed sores, and the diabetic foot ulcers. So these are the examples for the chronic wounds. So now you know the acute wounds and the chronic wounds. So acute wounds follow the normal physiology, and they follow the normal stages of wound healing. But the chronic wounds, they take more time, and they are not healed properly because they are actually trapped inside the wound healing cycle. So this is very important 4 points to understand. In order to have proper healing, their wound base should be well vascularized. There should be a good blood supply. If there is no blood supply at all, then the proper healing will be impaired and wound will not heal. And the wound base should be free of devitalized tissues, the wound debris, and the necrotic tissues should be removed in order to have proper wound healing. So, and also the wound should be clear of infectious burdens, and there should be appropriate hydration. So now let's see initial care of an acute wound. So in an acute wound, let's say a cut injury, a step injury. So usually we have to irrigate. Usually we can use normal saline, and also if there's no normal saline, we can use even tap water, which is clean. And the surgical debridement can be used to remove the devitalized tissues and debris and dirts, and clear out the wound bed for the proper healing. Now you can see the initial care of an acute wound photograph. So this is they are showing the proper irrigation of an acute wound. before the debridement. Now let's move into the chronic wound care. So as you can see, the normal wound healing cycle is hemostasis, and then inflammatory phase, and the proliferative phase, and the remodeling of the soft tissues. So in chronic wound healing, there is a disruption of the normal stages of wound healing. The inflammatory phase is too long and it is continuous, and there's a chronic inflammation, and wound healing cycle does not complete. So the disruption of wound healing is maybe due to impaired angiogenesis and impaired innervation of the area and impaired cellular migration. The comorbidities such as diabetes, autoimmune diseases, peripheral vascular diseases, and high BMI also are contributing for the disruption of the wound healing cycle. And also sometimes the anatomical location and the medications that is taken by the patient are also cause the disruption of the wound healing cycle. So in a chronic wound care, the first and most important thing is wound preparation. So by preparation of the wound bed, we are creating an optimum environment for the wound healing. And we have to treat the infections and cellulitis, and usually we treat with antibiotics, but not all the chronic wounds need antibiotics, and we can send cultures from the wounds and look for the specific antibiotics. And the patient should have a good glycemic control, and the patient should get good nutrition, and pain management also very important. So wound bed preparation. So it is the process of removing the local barriers to wound healing, and they maximize the potential for a successful healing. So we can primarily do the surgical debridement, and there are other methods such as enzymatic, biological, and some adjunctive therapies as well. So surgical debridement, they require planned serial debridement to sufficiently prepare the wound bed and they restore the normal optimal environment for the wound healing. The sharp surgical debridement is what is most appropriate. They remove the large areas of necrotic or infected tissues, and it is always indicated when there is an evidence of infection such as sepsis and cellulitis. So it is very important to send wound culture and look for the appropriate organism that is causing the wound infection. So it's a surgical debridement. So the other therapies, the other debridement methods such as enzymatic debridement using the collagenase, papain and bromelain, like exogenous enzymatic agents also can be used, and the maggot therapy, which is also known as the biologic debridement, is used when we can't do the surgical debridement. So even in the maggot therapy, there's larvae of the bowfly or the green bottle fly. They secrete proteolytic enzymes that liquefy the necrotic tissues. So, okay, another important entity is the vacuum dressings, also known as the negative pressure wound therapy. So, when negative pressure wound therapy systems, they continuously or intermittently apply subatmospheric pressure to the surface of the wound, and that will help to remove the slough, and they promote the development of the granulation tissue to cover the deeper exposed tissues. So it is proven that time of closure of diabetic foot ulcers and wounds resulting from diabetic foot surgery are reduced by the negative pressure wound therapy. So, and also using the negative pressure wound therapy, we can send the patient home with the VAC machine, and that will shorten the length of hospitalization, and also they have proven to decrease the complication rates and reduce cost for the patient. Let's move into the wound packing. So when there is wounds with large soft tissue defects, we can use wound packing to reduce the dead space. And also they are important to absorb the exudates or the seroma out of the wound. And also they reduce the potential for the infection, and they are very important as a temporary dressing. So gauze packing, which is very commonly used, which will aid with the ongoing debridement of devitalized tissues from the wound bed. So we can use the gauze packs that is moistened with the normal saline, and they are placed into the wound and covered with dry layers of gauze. So when gauze dries, it adheres to the surface of the tissues. Therefore, frequent changing of the gauze packing is very important. 2 to 3 times daily is important. And when all the slough is removed, or when all the necrotic tissues has been removed, it is important to discontinue the gauze packing, because it can damage the granulation tissue when it becomes dry. So there are topical dressings that forms alginate dressings, hydrogels that can be molded into the shape of the wound, and they are also very important and useful for the wound packing. We'll be discussing about the wound dressings in a short while. So wound dressings. So especially in a chronic wound, the following debridement, it is important to use a suitable dressing for the wound and appropriately maintain that optimal healing environment. So the moisture content of the wound bed must be kept in balance. Dressings are typically changed once a day or every other day to avoid disturbing the wound healing environment. So according to the water retaining abilities, they can be categorized as open, semi-open, and semi-occlusive wound dressings. Now let's discuss a little bit about these wound dressings. Open wound dressings. Primary gauze. We usually moisten them with the normal saline before placing into the wound. They are very inexpensive but often require frequent dressing changes. So as I described earlier, they can be used for the wound packing. Next, the semi-open dressings. They usually consist of fine mesh of gauze impregnated with petroleum, paraffin wax, or other ointment. They are also with minimal expense, and they are easy to apply. But usually they do not maintain moisture-rich environment or provide good exudate control. We use them for burns, skin grafts, or donor sites. Now let's move into the semi-occlusive dressings. So usually we are using them for the chronic wound management. So there are a lot of semi-occlusive wound dressing types. They have different absorptive capacities, conformability, bacteriostatic activity. So we can commonly divide them as films, foams, alginates, hydrocolloids, and hydrogels. The films are polymer films, which are transparent sheets of synthetic self-adhesive dressings. So they are permeable to gases such as water vapor and oxygen, but they are impermeable to large molecules including protein and bacteria. So these films are important to maintain moisture. They encourage rapid reepithelialization, so they have self-adhesive properties as well. So there are disadvantages with these films. So they have limited absorptive capacity. So usually we don't use films for moderate to heavily exudative wounds. So next, the foam dressings. They are also like films with addition of absorbency. So as I described earlier, the films have the absorptive capacity, but these foams usually they have wood absorbance. So they have two layers, hydrophilic and the hydrophobic layers. The hydrophilic layer is lysed against the wound surface, and the hydrophobic layer prevent the leakage and bacterial contamination. So the advantages is, as we discussed, the high absorptive capacity. They can take the shape of the wound and can be used to pack cavities. So they are not appropriate on minimally exudative wounds, as they can cause desiccation of the wounds. Alginates. So they are natural complex polysaccharides from various types of algae. They are insoluble in water but in the sodium-rich wound fluid environment. But in the sodium-rich wound fluids environment, these complexes exchange calcium ions for the sodium ions. So that forms an amorphous gel that packs and covers the wound. So they are appropriate for moderate to heavily exudative wounds. Advantages are augmentation of the hemostasis. They can be used for the wound packing and can stay in place for several days. So the disadvantages: they require secondary dressings that must be removed to monitor the wound. So can be too dry on minimally exudative wounds, and they also have an unpleasant odor. Next type, the hydrocolloids. They consist of a gel or a foam on a carrier of self-adhesive polyurethane film. So this colloid composition traps the exudates and create moist environment. So the advantages are bacteria and debris are trapped and washed away with the dressing changes, and they have ability to use them for packing wounds. So they are also having a malodor and has a potential need for daily dressing change. So there are hydrogels as well. The hydrogels are matrix of various types of synthetic polymers with 95% water formed into the sheets, gels and foams that are usually sandwiched between two sheets of removable film. So advantages are initially lower the temperature of the wound, which provides cooling and pain relief for some patients. Disadvantages are so there are some topical therapies which are commonly used in wound care. The antiseptics and antimicrobial agents, iodine-based, silver-based, and honey. And some topical therapies using the beta blocker timolol and growth factors. So iodine-based, cataxoma iodine, commonly known as iodosoap, is an antimicrobial agent that reduces the bacterial load within the wound. They may support healing by providing moist wound environment. So bacteria is either to all gram-positive and gram-negative bacteria. So that will promote wound healing. So, and silver-based dressings, they are toxic bacteria, and they used to decrease the heavy bacterial surface contamination. So some tips to tackle down complications of chronic wounds. So odor is one of the most unpleasant things associated with chronic wound issues. So odor can be tackled with interval mechanical debridement. Move with the serial debridement of the wounds, the odor usually decreases. And the topical antimicrobial therapy with metrogel can also be used to reduce the odor. There are odor absorbing dressings such as that have absorptive charcoal within the dressings, such as Actisoap, Carboflex. They can be also used. And if we are soaking the wounds with dilute acetic acid, hypochlorous chlorous acid, or dark solution, can be help to minimize the odor. So bleeding in chronic wounds. So the non-adherent dressings can be placed directly on the friable wound to reduce the bleeding. Topical hemostatic agents or sucralfate can also be used. So we can use gentle pressure with elastic bandages as well. To the focal points of bleeding, we can treat with silonitrate and epinephrine. The patients with pruritus, by keeping the proper moisture balance and protecting the skin will help to reduce the itching and skin irritation. We can use topical corticosteroids as well. So the exudates, an absorptive dressing should be placed over the non-adherent dressing to control the drainage and reduce peri-wound maceration and control the amount of exudate in the wound. So to control the exudates, we can use the VAC dressings, also known as the negative pressure wound therapy. Exudate absorbing topicals, including cardaxamide and medical honey formulations, can also be used to reduce the exudates. So some tips: wound coverage. So it is important to address the underlying etiology of the wound prior to performing the definitive procedure to minimize the risk of recurrence. So the primary closure can be done to a wound if it is relatively small. Larger or more complicated wounds may require grafts or flap coverages. Little bit about diabetic foot management. So we usually get a lot of patients with diabetic foot ulcers. So we usually what we do is we identify the level of the lesions, and we usually do endovascular treatment methods such as angioplasty surgeries, and provide good blood supply to the wound. So with having a good blood supply to the wound, the proper wound healing will be started. We can heal. So we can heal deadly diabetic foot ulcers. So the best practices in wound care. So we usually do not use surgical spirit or hydrogen peroxide to wash wounds. And when we are doing wound packing, we should do light packing unless there is active bleeding. So, and it is very important to do light dressings and do not do the tight dressings. And it is very important to use the correct dressing type. And one other important thing is educate the patients and caregivers about this wound care. So this is the end of the short video, and if you have any questions, please comment down below. And if you are having new suggestions, please comment them as well. So thank you very much for listening to this short video, and I'll be back with more videos soon. Thank you very much.